Okay, this video is to discuss the diagnosis of TB. This is the second video of TB, and the third video I'm going to talk about the treatment, prevention, complications of TB. Okay, so this is the second video. How to diagnose TB. The TB is diagnosed by laboratory and imaging studies. Okay, when you suspect TB due to, for example, an exposure to a patient with the disease, or symptoms that indicate that the patient may have TB, you have to do laboratory and imaging studies. Okay, let's start with the first thing, the tuberculin skin test. Tuberculin skin test is the first thing to be done, and actually tuberculin skin test is only done for high risk patients. Okay, and for patients with latent TB. Okay, so it's not for active TB if the patient is not a high risk patient. Okay, it's not diagnostic. You can't confirm the presence of TB with this test because it has a false negative and false positive value. Let's start with how to do this test. This test is done by intradermal injection of 5 tuberculin units. Okay, so you inject tuberculin units in below the skin. Okay, and the tuberculin unit is purified protein derivative. So you inject the antigen of tuberculin. Okay, this is the hand, and you suspect the body to respond to this weak antigens. Okay, and if the body responds, so you have TB. Okay, so the other name of the tuberculin skin test is Mantox test. So you inject intradermal injection of 5 T unit, tuberculin unit, okay, which is a purified protein derivative. Where do we inject this? On the volar aspect of the forearm. Okay, so it is positive 2 to 6 weeks after the onset of infection. Okay, so the result of the tuberculin skin test will be positive only after 2 to 6 weeks. So if you did the tuberculin test at the beginning of the infection or before 6 weeks, most probably you will have a false negative value. Okay, so again, the response to tuberculin test is respond for the antigen of tuberculin as a manifestation of delay hypersensitivity reaction. So the goal of the tuberculin test is to detect the immune response to Mycobacterium tuberculosis. Mycobacterium tuberculosis, again, is an investigation can be done for active TB, especially if you have high risk patients. Okay, and screening for latent TB. Okay, a tuberculin skin test is preferred in children less than 5 years. Actually, older than 5 years, we use other thing, which is interferon gamma release assay. The interferon gamma release assay directly detect the presence of cytokines that released by lymphocytes that are released in response to TB. So when you have TB, okay, lymphocyte will release. This lymphocyte will release some cytokines. Okay, and these cytokines will be detected by this test, the interferon gamma release assay. This is for older than 5 years, but still we can do the tuberculin skin test for older patient. Okay, even in adults we can use this examination or this investigation. Okay, let's watch this video about how to apply this.
Please call Algoma Public Health to report any positive TB.
Okay, so the bad news about the tuberculin skin test is that it has false negative and false positive value. What do we mean? The tuberculin skin test depends on 3 factors. Okay, it depends on the antigen that we administer to the patient. Okay, the antigen, and it depends on the immune response to this antigen, okay, to the immune response to this antigen, okay, and it depends on the time you apply this maneuver or procedure, okay. So we can have false negative values if the antigen that we administer to the patient is not good enough, if it is inactivated due to, for example, poor storage or inadequate administration, okay. So if we have an inactivated antigen and we have false tuberculin skin test, then it may be false negative value, okay, false negative value. If we have immunosuppression, there is not enough immunity to attack this antigen due to, for example, malnutrition or overwhelming of the TB or for AIDS, okay, then we can also have false negative value. Also, again, if the test is applied before 2 to 6 weeks of active from the onset of infection, okay, then it may have a false negative value. Also, we can have a false positive values in cases of malnutrition. Again, may cause false positive values, the book say, okay. If in the case of malnutrition, we should repeat the test after 3 months, okay, and during these 3 months we have to apply treatment. So because of the presence of the false negative and false positive value, the tuberculin skin test alone is never enough to diagnose TB, okay. So we have to add something that is diagnostic. Culture, the culture is ultimate diagnosis confirmation of TB. It is more successful, okay, than the tuberculin skin test, okay. The culture is best to be done with tissue such as pleural or pericardial membrane, better than taking fluid. So if you were able to take a tissue from the pericardial or the pleura, it's much more better than any fluid can be taken, okay. The sputum actually is excellent source in adult, but in children difficult to obtain the sputum. You can't tell the child to give you a sputum, so we take gastric fluids via NG tubes that are administered into the stomach, okay. Large volume of fluid like in CSF and pericardial fluid is not of that great benefit because it has high rate of survival of the microorganisms. So microorganism can survive among all these fluid in CSF or pericardial fluid. So sputum is good, tissue is the best thing to be taken, okay. But the bad thing about the culture that I've mentioned is it has slow growth, and this made it less helpful, okay, in active cases or in dangerous situation. So we have to apply the tuberculin skin test, as I told you, in high risk patients is very beneficial, okay. So we have other techniques like PCR and antigen detection probe, okay. Those other techniques are good, okay, but the problem that they are sensitive, but they are not specific, and they may give you false positive values, especially in PCR. So the mainstay diagnosis is the culture is the best way to diagnose. It's slow, so we don't we have to do tuberculin skin test in the emergent cases, okay. Imaging studies. The imaging studies is studies that we use at the same time we do the other laboratory studies, okay. Chest x-ray must be done in any patient we suspect to have the TB. Okay, all loop segments are at equal risk of the TB. Actually, we have some differences in the chest X-ray appearance from the primary TB and the TB reactivation. Primary TB, you mostly see hilar lymphadenopathy, okay, pleural effusion, pulmonary infiltrates, and so on. Okay, in TB reactivation, you may see TB that are confined to one loop. The apical posterior segment are frequently involved in this case. Okay, you may see multiple loops that are affected by the TB. Okay, you have very important thing, that cavitation and air fluid levels. Okay, in TB reactivation, very very important, cavities and air fluid level. The apical posterior segments. Okay, atypical presentation of X-ray in TB, okay, happens mostly in adolescent. You may see a pleural effusion, solitary nodule. This is an atypical presentation, mostly in adolescent. Okay, pleural effusion, solitary nodule, hilar lymphadenopathy with right middle collapse, right middle lobe collapse, upper lobe calcific changes. So calcification, the fibrosis, the pleural effusion, solitary nodule are atypical presentation, mostly seen on the adults. So this is multiple X-rays on the this subject. Okay, in A we can see primary tuberculosis. Okay, in child, this is a hilar lymphadenopathy and the lower lobe is affected here. Okay, we have infiltrates in the lower lobe and decreased lung volume loss in lung. Okay, this is the second picture. We can see pleural effusion, infiltration of the lower loop of the left lung. Okay, here we have hilar lymphadenopathy again and advanced TB. What is that? This is miliary tuberculosis. I told you about miliary tuberculosis. This is how it appears. Okay, here we can see TB cavitation. This is a cavitation. Okay, and this is mostly due to reactivation TB. So in TB reactivation we see cavitation. Okay, here we have infiltration of the lower lobe. This one is very nice. Here we have a middle loop infiltration. Okay, here we have hilar lymphadenopathy. Do you remember when I told you about the Ghon's complex, when we have hilar lymphadenopathy, granuloma plus parenchymal granuloma? Okay, so this is Ghon's complex when you have hilar lymphadenopathy, or I'm sorry, lymph granuloma plus parenchymal or lung granuloma. So this is about the lung TB. What about the extrathoracic finding of imaging in TB? Okay, you can do a CT scan or MRI to detect the bone TB. What you can see multiple lytic lesions in bone. Okay, as I told you before, and you can find a spinal deformity, for example, or anything in the spine that can indicate the presence of abnormality in bones due to bone TB, collapse, for example, of the vertebral bodies, destruction of the vertebral body, narrowing of the disc space, all these findings. Also, we have a brain TB or a meningitis, okay, due to TB. So you can do again CT or MRI of the brain. Okay, maybe normal during the early stages of the infection. Okay, but when the disease progresses, you can see hydrocephalus, for example, cerebral edema, or focal ischemia. Okay, anything can be found due to the meningitis of late TB. Okay, so this is all about the diagnosis of TB. Tuberculin skin test, the culture is the diagnostic. Okay, and the PCR other examination, the imaging studies, the miliary TB, hilar lymphadenopathy, the loop infiltration, the cavitation, the miliary I told you, okay, and the pleural effusion. The upper posterior loop is inactivated, reactivated TB is affected frequently, okay, and the CT MRI for bone and for brain. Thank you very much. See you in the next video talking about the treatment, prevention, complication of TB.